I think it was very good discussion. I think the points that were raised by the commissioners are all ones that will take to heart on the part of the staff. The point that the chair made about some of the issues related to what constitutes an interested party in the process through which a contested case can be is prosecuted, if you will, can be addressed through changes to the procedural regs. The broader policy and aspirational issues of the state plan really, I think, are topics for our strategic planning initiative. The preambles, if you will, to some of the state health plan chapters really lay out some very broad objectives, but the regulations themselves, as Paul described, are rule-based, and I think we can think about how aspirational elements could be included in some of those plan chapters where they are highly relevant. So we'll look forward to that discussion, but I thought it was very helpful for staff today.
Thank you, and thank you for the commissioners who participated. Turning to agenda item number 6, Maryland MCDB data request application by Johns Hopkins Center for Public Health IT. Under our statute and the regulations governing access to MCDB data for research use, the Commission must approve an application for MCDB data prior to the release of MCDB data to an applicant. The Center for Population Health IT, Johns Hopkins Bloomberg School of Public Health, has applied for the MCDB data. The applicant will use MCDB forms, HSCRC hospital records, and information from the Office of the Chief Medical Examiner to enhance Maryland's statewide suicide data warehouse for predicting suicide risk and preventing death by suicide. It says here that Mahi Kanjit Solomon, Chief of
mentioning. Yes, Mahi's at one today.
Is it Ken?
It's Mahi's at one today. So
Chaplain will give the
I'm
presentation.
stepping in for Mahi. Hope she gets well soon.
Very good.
Thank you, Chair Parkman, Chair Sargent. Sorry about that. And Commissioners, good afternoon. Basic Director, staff, and members of the public to be here today. Next slide, please. In the process of how we actually use data, we govern it by the COMA 102505, and there's an application that the applicant fills out. An application is posted for public comment, and the Data Release Advisory Committee use public comment to view that data, and then also a DUA is actually formed, and then the track recommends the application to come to the commission. That is why we are here today. Next slide, please. So the applicant, in this case, is the Center for Population Health IT, Johns Hopkins Bloomberg School of Public Health. On the left-hand side of the slide, Johns Hopkins, I will refer to as Johns Hopkins, have successfully had 5 projects in which they have used the MCDB in the past. But today, the applicant is requesting MCDB data for research project for advancing Maryland's statewide suicide data warehouse to improve individual and population level mortality prediction and prevention. There has been increased interest in developing models, predictive models, to identify the individuals at risk for suicide. The National Academies of Science, Engineering, and Medicine are currently hosting a series of webinars using data science approaches to identify individuals, population communities at high risk for suicide. Next slide, please. In terms of the project, the purpose of the project is to refresh the Maryland Suicide Data Warehouse and acquiring new data from different sources, and application of descriptive findings, develop and assess hypothesis-driven techniques to predict suicide death. Also to explore hypothesis-generating use cases of the Maryland Suicide Data Warehouse and to evaluate the generalizability of data sources and methods. In terms of the data sources that is going to be used for this project, the MCDB data will be linked to the Office of the Medical Examiner by a crisp encrypted EID. Other data sources will be from the HSCSE, Johns Hopkins Health Systems, Anne Arundel Medical Center, Peninsula Regional Medical Center, Veterans Health Administration of Maryland, and Chris Insight. So the proposed project, will compare individuals who have died by suicide to those who have died by other means as specified in the Office of the Medical Examiner data. The project is proposed to build a complete control population as recommended by the National Institute of Mental Health. The project will also develop a more generalizable predictive or prediction model. Also will develop predictive analytics using statistical approaches to identify suicide deaths. I also will construct a retroactive case control study exploring suicide as recorded by the medical examiner and other cases of death. And the analysis will be studied by race, gender, insurance type, and other attributes as needed. Funding source for this project is the National Institute of Mental Health. Next slide, please. From the project, the data requested would be the MCDB eligibility files and all the claims files, professional services, institutional services, and pharmacy services claims file for the privately insured data and also the Medicare managed care data for the years 2016 to 2020. The projected time period for this project is a 2-year period, which will span 2022 to 2024. From a results outcome basis, the results on the project will be disseminated through published peer review manuscripts and conferences. Additional aggregate results may be shared with the funding agency, NIMH, as requested by the National Institute of Health Guidelines. The data fees for this project will be $96,000, and it will be based on a new fee schedule which will become effective June 16, 2022, after a 30-day notice. Next slide, please. Today, we have the Hopkins team, Heidi Karazi, which is Associate Professor and Co-Director, Thomas Richards, who's Technical Director, and we have Denise Laser, who is Research Associate and Center Coordinator. Next slide, please. So upon review, staff have determined that the application meets the regulatory requirement of research use because the aim is to leverage the unique data types linked by the Maryland Suicide Data Warehouse to improve suicide death predictions among a more generalizable patient population in Maryland. Staff also reviewed and says that the application meets the regulatory requirement of being in the public interest, as the MCDB and other data sources and other data could be linked to data from suicide prevention efforts to help identify which interventions are most effective in preventing suicidal behaviors and who benefits from specific interventions under what conditions. Predictive models of suicide death will be available to the public and can be adopted by various health systems and insurers. Therefore, staff recommends the Commission to vote to approve the MCDB data request application submitted by the applicant Johns Hopkins created Center for Public Health, IT, Johns Hopkins Blumenberg School of Public Health, and provide access to the required data. Staff also recommends that the Commission approve the applicant's request for the requested data until the end of 2024, beginning on the dates the data use agreement is executed, and the new tiered fee schedule effective tentatively June 16th. Next slide, please. Next slide, please. That is my end of my presentation. Any questions?
Very good. That's sweet. Yeah, we can do questions first. Commissioner Boyle, I see your hand up.
Yes, thank you. I mean, this looks like a great project. It's not, I don't question that. This is the first project I've seen that they're actually paying for it and they're not asking for an exemption to that. I'm just a little curious about, like to better understand why, what is the payment structure? How was that developed? And I do know that we have exempted many, but is the amount of money, is there fear that that stands in the way of some people applying?
Well, that's a very, very good question. Well, we as a commission do not want payments to be an hindrance to use ABCD, expand ABCD. And in terms of, for this case and going forward, we have a new fee structure based on a tiered basis. So what that means is that for an applicant who, to have a discount, applicant will apply for the data for at least 3 years or more to really get the discount. So in this case for Johns Hopkins, they are applying for the data for 5 years. So for the first 2 years, there will be no discount. Starting in year 3, there will be a 25% discount. Year 4, 25% discount, and then in year 5, there will be a 50% discount. So, so for this case, for the private data, that will be $48,000. For the Medicaid data, that will be another $48,000 for a summation of $96,000.
I noticed Dr. Karazi is on the video, and I wanted to thank you for coming. So if commissioners have a question, he is also here with us. Are there any other commissioners who have a question or discussion?
Yes, I do, Randy, if you have a second.
Go right ahead.
Okay, so I think this looks like a great project. And I would say to my fellow commissioner, I think NIH is picking up the bill for this one, and so I wouldn't worry too much. They have pretty deep pockets. So I think it's, and because we do at times waive and make it, below the regular rate, that hopefully should avoid any kind of chilling effect on less well-funded researchers coming forward. The main thing I wanted to say here is I think this is, I like this project. This looks very good. And not only, the only question I have is about the dissemination plan. And this is simply a suggestion. I'm still very fully supportive. But it is taking a traditional academic style dissemination plan. We're going to publish. And God knows, we all understand you have to publish. You need this. That's how you move up in your field and things like that. At the same time, there are so many, let's call it applied uses for this modeling if you are successful. I would ask you to consider not only sort of this dissemination plan that is the traditional academic style, which I'm sure NIH will be quite comfortable with, but in my experience, there's been too many times when there's good models like this in the echo chamber of an academic audience, and the people who are actually trying to help reduce suicides are just unaware of it. So I would ask you to consider, do you want to try and when you've got something, hopefully it's good and you're comfortable with it and you've got it published, you're not trying to, but I would say go back to the state of Maryland and if you'd like to come back to us, I'd love to hear about what you actually find and how robust this model is and how well it predicts and how well it does for different demographics or different vulnerable groups. But I think if you are successful, there is great potential for this to do more good than publication. And I would ask you to consider how you get this to more the practitioners who are actually on the ground, whether it's county level, state level, federal level. This is, the Surgeon General has a big program at HHS. There's these things. This should not sit and go, be published in a peer reviewed, but then kind of a report that sits on the bookcase at NIH. Because candidly, my experience at HHS for a number of years was that's far too often what happens to this. And so the Medicare people actually never see it, the SAMHSA people never see it. It never gets out there because those guys are in a different world and they're not going to sit around and read your journal. So it's just a suggestion, but if you really want this to make a difference, I think you've got to think broader in your dissemination program.
Just a comment along a segue with Commissioner Grady said. I think it'd be a great idea if they can predict the inclination toward suicide. I wonder if they can use data and predict violent behavior. I mean, just a thought.
So I had a question, maybe more of a comment, Ken. It's similar to what Commissioner Grady just said. I think this is a no-brainer, so it's not really about this, but I would love to see just a general program that maybe not program, but general practice we have where we've contributed to research by putting our data in. And a paper comes out. Are we collecting those, making sure that folks are aware that we've contributed to that research? Do we have a process in place for tracking that, for getting the results, and for helping to share them ourselves? And what can we do on that end, in addition to the excellent suggestions for the researchers? But it's good for us, it's good for the research, and things like that. So I don't know if it's so much an answer, unless you already have one in place, but or something to think about.
Well, not only in this research as well. I know Dr. Rising will present the commission on its findings, but we with our contractor we are looking to